Thanks everybody for being here. We're going to get started. It's truly my privilege and pleasure to welcome all of you to Bioethics Grand Rounds. Today is a particularly special topic and one that is important to the entire Michigan medicine community, and one that, quite frankly, our group is privileged to be able to continue a conversation that I think really should be had. I am Andy Shuman. I am one of the chiefs of the Clinical Ethics Service for the Center of Bioethics and Social Sciences in Medicine, and Dr. Christian Vercler is my partner in crime who helps run our service as well. As part of our privilege in this role is to host Bioethics Grand Rounds, where monthly we will have topics of interest to the larger Michigan community, and today is no exception. The topic for today is to examine in a critical way how we think about concierge medicine in the 21st century, and specifically here on our campus. The Victor's Care program is a new initiative coming out of our institution, and one that has generated a fair amount of interest and discussion, which is the purpose of our plan today. Our panelists really need no introduction, but I will introduce them anyway. Marschall Runge is the Dean and Executive Vice President for Medical Affairs of our institution. He's been here since 2015, having come from a similar position at the University of North Carolina. He is a clinician by trade, having completed his training at Vanderbilt University and then Johns Hopkins. He is a cardiologist and a thought leader within his field, as well as in academic medicine broadly. Our second panelist is Dr. David Brown, who is the Associate Vice President and Associate Dean for Health Equity and Inclusion. He is an otolaryngologist, a pediatric otolaryngologist who works in Mott, who also is extensively involved in the Global Reach program with work in Kumasi, Ghana, and has trained at Brown University, Harvard Medical School, and did his additional training here. The third panelist is Reshma Jagsi, who is the Professor and Deputy Chair of Radiation Oncology and the Director of the Center for Bioethics and Social Sciences in Medicine. She's a graduate of Harvard College and Harvard Medical School, and a graduate of the Ethics Fellowship at Harvard University, followed by a doctorate at Oxford as a Marshall Scholar. She is a breast cancer expert, but also has done really groundbreaking work in patient decision-making, cost and access to care, and social scientific research involving bioethics in cancer care and research, specifically looking at gender issues and harassment. The order of business for the next hour is for us to listen to a brief presentation from the Dean to start, after which we will have a roundtable panel discussion. We have many questions that have been submitted in advance on Qualtrics. I have about 50 plus questions here that I'm prepared to moderate, but we'll stay as long as we have to. And then we also have little notepads and cards coming around, and anybody who has a specific question, feel free to prepare that and just raise your hand, and we have a couple of folks who are going to be wandering around to grab them, and we will do our best to get to as many as possible. I will not be reading them verbatim, simply to be able to combine those of similar interest and similar topic together to try to get everybody's input. With that said, it is truly my privilege to introduce our Dean. Sir.
Thank you, Andy. Thank you, Christian. Thank you, Reshma. And thank all of you. It's an opportunity for me to be here today, and my goal is to help you understand what Victor's Care is, what it's not, what the goals are, how it originated. I read through the 50, or seemed like more than 50 questions, and I'll try to touch on a few of those, but I really want to restrict my comments to just 6 or 8 minutes at the most to kind of give you a high-level overview. And I think one thing that's really hard in a big organization is to have the chance to speak to large groups of people and tell them what my thoughts are, what our thoughts are about a program like this. My goal is not to change anybody's mind, change anybody's passion, but rather to just be sure that I completely hear from you about concerns and that you understand where we're coming from. So, relatively simple goal. Probably more simple than my advancing the slides. Let me try the keyboard. Okay. So So the Victor's Care model. This is a model that is variably called across country concierge care or executive wellness. It's a dedicated physician for Victor's Care patients, a dedicated off-campus office space. We're not taking any space in our current model out for Victor's Care. It's actually a separate entity. It does feature and is primarily a primary care model, 24/7 access to that dedicated physician, but an office that provides for enhanced care coordination. I'll come back to this in a moment, but one of the questions that always comes up when I speak to people is this a way to jump the line? So we have long waits. You know this as well as I do. Long waits for in every area of clinical practice. It's a tribute to all of you that provide health care. And I just want to be very direct. This will not jump places in the line. I'll explain to you the opportunity to have people both as part of this program and people who are part of other programs get more rapid access. And I'll come back to that in just a moment. And as we think about the questions, I think you touched on many topics in your questions that I think Andy will ask us about. But if you have questions, specifics about the program, I'm happy to answer those either today or later. But I think the start today is more at a high level from an ethical standpoint. So why are we offering this? Well, we're offering it for several reasons. One is there's a lot of patient interest in this I heard about when I first came in the door. It is a separate healthcare portfolio. The cost is about $2,700 a year. For those of you who, like me, use a health savings account, the maximum you can put in that is $2,500 a year, so you can almost pay for it out of your health savings account. There are no additional charges, no co-pays or anything for your primary care. Importantly, one of the questions that was in the list was, why hadn't I said what the goal is? I am responsible for really pushing us to do this program. It had been talked about for a long time, but I thought it could work based on my past experience. And I want to be very concrete about why I think this is a value. I think it's a value because I think that primarily it is a way to bring supporters, and we have many supporters, into our system in a way that they will learn more about healthcare and they will donate toward healthcare for people not as fortunate as they are. Now, the bar is not terribly high. $2,700 is not to be sneezed at, but that covers a broad swath of people who could participate in this, but it'll be capped at 600 patients. So that's approximately 1,000th the number of unique patients we have in our system. So relatively speaking, a small number of patients. I want to make one other comment about that. A couple of weeks ago, I was in Florida. There's an annual event you may have heard of called the Florida Seminars, which is basically a development event. Faculty, maybe some of you have been there, you give talks, and our most generous donors are there, and we seek support for different kinds of programs. As I do every year, I sat down individually with about 10 of these highest profile donors, and the first question they all asked me about was Victor's Care, and half of them were signed up, the other half were curious about it. But what all of them said to me was, they said, we'd like to learn a lot more about this because nobody's ever asked us to donate to care for people that are less fortunate than us. They ask us to donate to very exciting research, or they ask us to donate to other kinds of programs or buildings. And of the 10 I saw, 6 of them, I think, would donate funds, and they're substantial donors, to supporting our ability to carry across our broad spectrum of patients. That's an important issue that I'm going to also point out on this slide. So, you know this, I know this. Of the patients that we care for, and the demographics across the United States, about 9% have no health care insurance, 90% are government insured, and they have a variety of levels of insurance. I think with where things stand, and I don't want to get into a political conversation, it's not likely that this is going to improve in the near term. I would guess this will get worse in the near term. So as I thought about this, I thought, how do we continue to expand our mission to those who are less fortunate and they're underinsured or uninsured or hampered by their social settings that they can't really participate in much of the care that we offer. And there's about 15% of the population that can easily afford this kind of care, and as you'll note, I'm noting them as donors. Now, another question that's come up that has been, well, why are we doing this for this upper echelon of society, and we're not doing anything to try to improve our care for the people who are most vulnerable? And I feel passionately about this. I was at North Carolina, which actually North Carolina, when I was there, our percentage of uninsured patients was right around 12 or 13% most of the time, truly completely uninsured. And we developed a program like this really because of a very generous donor who wanted to help provide funds for providing care through philanthropy. But in the meantime, we have been doing a lot of things. So I'm not going to go through all this in detail, but I can tell you that and we'll report more when we have final information, but for 6 months we've been doing something we planned for 2 years, which is optimizing capacity use in our clinics. And we've seen a 10% increase in capacity across, when you take everything together, medicine and all the specialties, oto and urology, about a 10% decrease in wait time. That's not what I think should be our final goal, but 10% is not insignificant. So, for example, with pulmonary, that decreased the lag time for a new patient by 3 days. And that's from 40 to 37 or 35 to 31. It's not where we want it to be, but we've invested significantly in this, and we will continue to invest in this. We're talking about faculty workforce. We have 2 pilots that you may or may not have heard of that will be looking at redesigning workflow, one in general pediatrics, one in general medicine. They'll be starting up within the next month or so. They are focused primarily on physician burnout, but they're a pilot. And the reason to do this pilot is they will be staffed in a way very similar to Victor's. And we'll see. We'll see, does that provide the patient experience that we want? And if it does, and that's with their usual mix of patients. If it does, how can we expand that? Finally, and I'll talk about this later if you'd like to, when I was in North Carolina, we had a fabulous relationship with the local FQHCs. There were 5 of them bundled together into what was called Piedmont Health Services. We had an excellent relationship where they expanded our primary care database, particularly for people waiting in the emergency room. Part of that guarantee, there was a financial guarantee to the FQHC, which needed some stability, and there was a commitment on the part of the practice plan that patients who came through any of the FQHCs for any reason would have access to a specialist within a week, unless it was totally elective. That will involve many, many, many more patients if we can make this work here than Victor's will ever. It's not a solution, but we would pay for that out of philanthropy from Victor's. And so the program itself is not likely to generate much of a margin, but the philanthropy will, I believe. And we don't have any other area in which we intend to use those funds. Finally, these are numbers that you probably know, but our M-Support charity care is $67 million for FY17. We care for a lot of individuals who are underinsured or uninsured and have programs that we will increase over time. So I wanted to give you that kind of high level, but I do want to thank you for your coming. I want to thank you for your questions. I'm happy to come to other groups. If you have smaller groups, departments, I went to one department meeting and would like to dig more into the details of this program. Thank you.
Thank you very much. The first thing I wanted to do is give our panelists the opportunity to introduce themselves and comment broadly, and then we'll get into the questions more narrowly. So Dr. Jagsi?
Excellent. So the first thing that I wanted to do was actually get a sense of this audience, because I will admit that we don't quite have such a good turnout to Bioethics Grand Rounds ordinarily. So how many of you guys are what I would call Bioethics Grand Rounds faithful? You come at least a few times a year. You're typically here. of you turned up specifically because you were interested in hearing about Victor's care? And how many of you are primary care providers? How many of you are specialist providers? How many of you are patients? I'm guessing most of you are patients. all of you are patients, right? So what I would like to say is that I think this is a wonderful opportunity, and I think it's really absolutely amazing that Dr. Shuman and Vercler convened this session to engage the community in this way, because I do actually think that programs like this critically require the input of our community. And the decisions of how to structure these programs absolutely can't be made by wise leaders alone, nor by the intellectual elite in the ivory tower, nor by practitioners on the ground. It has to be involving every member of our community, including the most vulnerable whom we serve. Some of you who are among the faithful of Bioethics Grand Rounds will recall that I gave a Bioethics Grand Rounds in the fall, not quite as well attended, that was on the ethics of philanthropy and grateful patients and fundraising for grateful patients. And many of the issues that we touched upon in that context are issues that arise here. Issues of privacy and confidentiality with respect to how patients are identified to be solicited to participate in this program. Issues related to the well-being of those who participate, because we all know that shortcuts and unnecessary tests aren't actually to the benefit of people who participate, even though they might think that they are. And of course, issues related to equity and access. I will, as the designated egghead of the panel, give you just a very little intellectual framework within which to situate some of these considerations. So there are many approaches to bioethics, and I'm going to try not to make eye contact with all of those who disagree with Rawlsian approaches, but I'm going to give you one, because I don't want to belabor the point, but I want to give you a sense of how a bioethicist might approach this. So many of you may have read Rawls' theory of justice at some point in college, or political liberalism. And John Rawls was a philosopher who basically deliberated over principles of justice for the allocation of social and economic goods in society. And what he said was, we should think about a situation of hypothetical consent, where parties in an original position who are shielded behind a veil of ignorance that keeps them from knowing where they will end up in society, whether they'll be rich or poor, whether they'll be talented or not, or even what their vision of the good life will be. Those parties should deliberate over principles of justice to structure society. And parties that were rational and in that position would actually rationally arrive at two principles. The first principle is equal basic rights and liberties. And when we talk about equal basic rights and liberties, we talk about rights to things that one might need to be able to exercise one's free will and one's rationality and to pursue the vision of the good life that one has. And those include a fundamental level of education and a fundamental level of healthcare. And that's why Victor's Care is not proposing to allocate access to fundamental aspects of healthcare based on ability to pay. The second principle is the difference principle, and it states that parties who were shielded in this original position from their own characteristics would agree to differences in the allocation of other social and economic goods, so long as those differences were to the benefit of the least well-off. And that's why the aspect of Dr. Runge's presentation that is so important is relating to the uses of the revenues that come in, not just the profit from the system in isolation, but the philanthropic donations that it will facilitate. Because if those are used to help the vulnerable in society, then that in and of itself can justify differences in non-basic healthcare goods, but in convenience-related services and those other kinds of things. So I throw that out there for consideration. What we'd really like to do is hear from you, but first let's hear from Dr. Brown.
Thank you. So good afternoon. I want to thank Dr. Shuman, Dr. Vercler, and the ethics team for hosting this Bioethics Grand Rounds. Clearly, by the beyond capacity crowd, this is a topic that's important to many of us. Clearly, you all care about the mission of Michigan Medicine and the direction we're heading. And it's actually your engagement and your questions and questioning Victor's Care that actually brought us here today. So it's great to have a community of engaged individuals. When something that bothers them, they speak up, and it's also great to have leadership that is willing to listen to that. So thank you all. So as Dr. Shuman said, I'm the Associate Dean for Health Equity and Inclusion. I'm also a pediatric otolaryngologist. When I graduated from medical school, like others who are providers, I took an oath to take care of patients of all backgrounds, no matter their ability to pay or their race or ethnicity. And I took pride in doing that when I was in Baltimore, when I was in Milwaukee, when I was here, as when I returned here 6.5 years ago. When I took over the Office for Health Equity and Inclusion, similarly, I took a vow to advocate for diversity, equity, and inclusion for all our learners, all our staff, faculty, and our patients, despite their background, including their diversity, those who are racially and ethnically diverse and underrepresented, LGBTQ patients, patients with disabilities, lower socioeconomic status, people from rural areas, that I say disabilities, and anyone who feels underrepresented, marginalized, or excluded. Like many of you, when I first heard of Victor's Care, I had some concerns about how does this fit into our mission of diversity, equity, and inclusion. And I strongly, and I know from many conversations with Dr. Runge as well, I strongly advocate for equitable access and care for all patients. So I look forward to the discussion with you all and the panel today on Victor's Care.
Great, thank you so much. Just to remind folks, anybody who has a question, feel free to write it down on the pads and the papers that are circulating, and just raise your hand and someone will come grab them and pass them up to me. For now, I'm going to work through the questions that were submitted online, and the first one I'll address to Dr. Jagsi. So what are the necessary steps to set boundaries and expectations for concierge medicine clients, both to ensure that they don't adversely impact the care of other patients, but also so that they don't inadvertently receive inferior or unnecessary care themselves?
So I think that we need to actually engage the community in deliberation on exactly what the boundaries and expectations should be, as well as how we optimally communicate this. This can be very challenging. I think we all know how difficult it is to communicate the risks of false positives when we administer a test to a population with a low pre-test probability of disease. I mean, I think we all remember sitting through medical school and it taking us a good, it took me almost a week to actually really believe it after I worked it out. Seeing those charts and sensitivity and specificity and varying the prevalence of disease, and seeing that actually you could actually cause more harm than good by delivering tests. There are anecdotes that we can tell. The apocryphal story of the surgical department chair who gets a direct admission to the floor and has abdominal pain, and he gets to circumvent the long wait in the ED, and he actually ends up bleeding out from a AAA on the floor because he circumvented the process that are the normal processes of care. So we can explain why it is not always the best thing for a patient to receive a test or to take the shorter route through the process of care. But I think we need to come together to talk about how we do that. And with respect to what those boundaries and expectations should be, those need to be set by us as a community, including not just the people in this room, but those who maybe aren't empowered enough to even know that a session like this is going on. So we need to actually make proactive steps to including the vulnerable in our society.
Great. Dr. Brown, what are the challenges of implementing a concierge medicine program in an institution that has a committed vision and mission to promoting diversity, equity, and inclusion?
I think there are potentially many, either intentional or unintentional issues that we have to talk about. At first glance, when I first learned about Victor's Care, I think when we heard concierge care, that gives us certain images. I'm from the East Coast, and I hear about concierge care. When I look at it, it's actually more direct care. And so I'm wondering if we're even calling it the wrong thing, because it is not, from what I understand, supposed to be rolled out as some type of luxury type of care, but more direct care. One of the things that I worry about is that since people have to pay, that this excludes people from lower socioeconomic status, and this gives a tiered type of healthcare that you can have disparities based on race and wealth. Also, just from doing literature searches on this, I realized that there are fewer underrepresented minorities and Medicaid patients in these types of programs. For example, for African Americans, 7% in direct care versus in most other general primary cares, which is 15%. Hispanics, 4 versus 14%. Medicaid, 5 versus 15%. And when we are rolling out diversity, equity, and inclusion plan, and I know we live in a Prop 2 state, but one of our goals is to better reflect the society which we serve. And so I wonder how we can do that with Victor's Care. And further research has shown that in programs like this, up to 84% of retainer or concierge physicians do some charity care. And 17% see patients who do not pay the retainer fee at all. So my question is this a possibility with Victor's Care? The AMA has a position statement on caring for poor patients, and they state that each physician has the obligation to share in providing care to the indigent. Direct care providers can do this by seeing indigent patients at their offices at no cost or reduced cost, serving at freestanding or hospital clinics that treat the poor, and by participating in government programs and volunteering at shelters. So I'm wondering, is this a possibility with Victor's Care as well? Another thing which I found kind of interesting in my search is that in 2014, the state of Washington actually incorporated Medicaid patients into this. So they had a Medicaid program that actually paid for patients to participate in their direct care program. They enrolled 15,000 Medicaid patients, and they actually felt that the downstream effects of that they saved 20 to 30%. So is this a model that we can expand in the state of Michigan? If it's great for one group, can it be great for the others? One of the things that concerns me even more is that we talk a lot about unconscious bias, but also there can be these perceived pressures by healthcare providers. When the care coordinator calls you, do you feel that pressure to get them in sooner in the emergency department, to get that cath sooner, to squeeze them into your clinic, to overbook your OR day? And one of the things I worry about is what I've termed the health inequity creep, which means that over time, subtle things creep in and the disparity changes over time. And so what I think on the lines of Reshma's question is that we do need to evaluate this and keep on top of this and study this to make sure that we don't create disparities. And if there are opportunities, such as the care coordinator, how can we incorporate that into what we do for all our patients? I imagine lots of complex patients who may not be able to who may not be able to afford Victor's Care can use a care coordinator.
Can I?
Please.
I wanted to just continue what David said, because on several aspects. One is, I think whatever we end up doing, we need to study it. We need to understand it. We need to track it. You need to hold me accountable for all the things that I said will happen. And specifically with regard to access to care. So I forgot to say this. So for specialty care for patients in the Victor's program, that will be provided by specialists who wish to participate in the program. It will be in addition to their usual template. If they don't wish to participate, nobody has to participate. There will be no block. It's actually not even. It's impractical to think about blocking spots. But I think this works best as I've seen it work in several different circumstances, but one being UNC, when you have a balancing program like with the FQHCs, where they also have. We would identify a cadre of specialists who wish to see patients who are underserved and at risk the next day or within the next week. And I think we need to expand. One way to look at that is that's two ends of the continuum. Another way to look at it is there's similar programs, and how do we bridge them together?
Great. Some questions are trickling down. I'm going to take moderator's privilege and ask another one. So currently members of what I'll call the Michigan medicine family, which includes staff, faculty, and so on, have preferential access simply by knowing who to call and knowing how to access that care. And the analogy that's used is if you work at Kellogg's, you get free cereal. And if you work at Michigan Medicine, you have at least preferential ability to access certain aspects of care. And the question is, how and why is Victor's Care fundamentally different from that model?
You know, it is true. Probably many of us in this audience have advocated for a friend, a family member, or coworker to get into an appointment quicker. And, you know, to be honest, whenever anyone calls me about any patient, I try to work them in. A lot of times we can. We just don't know about everyone who needs to be worked in. The way I'm not an ethicist, so I'll put that up front. So maybe my answer won't be ethical. But I do feel that when we work at an organization, we get certain perks. You know, there's certain benefits. You get a 401k, maybe not great parking, but you get a perk if you work in this academic medical center, that you know people, you have access, and you can advocate for your friends and your family members, people who mean something to you. I do sometimes worry if they're not a part of the family, if that's not a part of the perk, unless we're considering donors part of the family. But I consider that, you know, since you don't get great parking, that maybe you do get a certain leverage as a perk.
So I have to say, I'm actually really troubled by the perk of being part of the family. I will tell you that I waited to have my back evaluated in PM&R for 6 months, and then I waited another 6 months for my steroid injection, and almost couldn't walk. And my department chair actually said to me, it would take me one call to say you're hobbling between patient rooms, and we could get you in. And I said, I don't want that call to be made. I actually find something really troubling about the fact that certain members of society are able to leverage relationships to have privileges in a very opaque way. And one of the things I actually like about Victor's Care is actually it democratizes this to some extent. Of course, there's some people who are absolutely not going to be able to afford $2,700. It's just not feasible. But at least it puts out there what the rules of the game are and what the expectations can be. Because one of the things that troubles me about donor facilitative services and the VIP services that we offer to donors and to members of our community are that you have to know how to play the game, and that can really disadvantage outsiders. And so, interestingly, there is this aspect of Victor's Care that actually addresses that particular concern.
So how do we mitigate the foreseeable conflicts with boundaries and expectations of instant gratification that some Victor's Care patients may expect or demand?
I will speak to that. Having participated in a program like this twice, once at the University of Texas Medical Branch, where actually the uninsured population, truly uninsured, was 40% of our population, and at UNC. And in both cases, I was asked to participate in the concierge care, and I felt it was part of my duty as a university citizen. And I also went to I participated in the Piedmont Health Service clinics in UNC and something else in Galveston. And I will tell you, no surprise to any of you who take care of patients who have means and have become accustomed to a certain level of service, it is quite possible to get unrealistic expectations. Whether it's about what test they want or are demanding to get, or whether it's about access in ways that there's no medical reason to do that. And I think it's incumbent upon the providers to level set that. One of the version of this question was, would anybody ever be dismissed from Victor's because of pushing this limit? And the answer is yes. And they have been excluded from programs like this. Now that's a long way from there to saying what I think we need Reshma and David's help. What are those boundaries? But I think it is totally realistic to expect that will be part of an issue we have to wrestle with.
Great. Did you have something? Okay. So the next question relates specifically to the pool, so to speak. So assuming we cap our 600, what is the patient selection process or approach going to look like? Is this going to be stratified by who is really going to be that big donor, or is that going to be stratified by other variables, or is it purely first come, first serve, or will the program expand depending upon the interest? And I put 4 questions together there.
Yeah. I guess I get that one, huh? As you know probably, but if you don't know, the initial solicitation, whether right, wrong, or in between, was sent to 21,000 Michigan medicine donors. That was the initial solicitation. And since then, there's informational sessions. It will truly be first come, first serve. The anticipation is that by summer, there may be 300 patients who are part of this program. We don't know yet. But it will definitely be capped at 600 until we figure out, is this a good thing? Is it a bad thing? How is this affecting our resources? Is it having the desired outcomes? I wouldn't say that there's no chance it will be expanded. I would say, as long as I'm here, there's no chance that it'll be with that group of people, that it'll be a 15,000 person event. And in some ways, and this may sound naive, but I believe this, this is one of many pilots we're doing around healthcare. And this one has a different slant to it, but it's no different than the pilot we're going to do with the pediatric general peds and the general medicine clinics, to see if we help physicians with burnout and if we provide a better level of care to our patients. And then we'll have decisions to make.
Great. Education and training are fundamental, if not the most fundamental component of our mission. And the question is, how are we going to engage our trainees, both students and graduate trainees, in the Victor's Care model, or help our trainees to learn from it or with it as either providers or observers?
Well, this is one of those questions I would love to get input on. I can tell you my experience, my thought is that it could be an elective. It shouldn't be a required clerkship of any sort, but it could be an elective. But right now, that is an unanswered question. We'd love to get input on that.
Yeah, there was a letter in response to the ACP statement on concierge care that specifically concludes by saying, students should absolutely never be involved. And I'm not sure I agree with that at all. I think there's quite a bit of learning that can go on in this context, including learning about the ethics of how we ensure that innovative programs like this are structured in ways that do not disadvantage the least well off.
And if we want to be truly inclusive of the aspirations of all of our learners and what their potential is in the future, we do know that every year 1 to 2% increase in the number of providers that provide this type of service, and this may be an option for some of our medical students to participate in this type of care.
Great. I'll segue to one of our other missions, which is research. And this seems to many, and I'm putting a few questions together, as a very intriguing area of empiric study. And we have an army of nationally, if not internationally renowned health services researchers. How, and this is really for the entire group, how can we best leverage this program's rollout, as well as the debate and dilemmas that it brings, to advance the science and truly learn from it?
Well, I think there's multiple components. If we can learn how to increase access, if we can learn how to increase the patient experience, if we can learn how to increase the provider experience, if we could learn how to set boundaries and figure out how technology works from this, there's so many opportunities that we can learn, and hopefully with the philanthropy from this program, we could extend that further on throughout Michigan Medicine to take care of all patients.
And I think those of you who were at Bioethics Grand Rounds in the fall heard that I've got a Greenwall Foundation grant proposal in right now, actually, that is seeking to gather empirical evidence about patient and public perceptions about what types of services can be offered to high donors, what appropriate approaches can identify donors, how we can solicit donors. And so we're actually actively engaged in doing this kind of research already, and this will provide, I think, a very important avenue for additional empirical research along these lines.
Yeah, I would just add, between the ethos of our organization and the experts we have and the accumulated expertise that is exhibited by IHPI, among other areas, I can't think of a place better suited to help address what is really a national question today. And I would just add, in case this is a question, anything that we learn, we will share. Now the question is how to best share it, but there are no secrets. My goal is for this to be fully transparent.
Okay. As an internist who tries to explain to patients why it's unprofessional to order test or referrals that the patients want but don't need, how can we trust that Victor's Care patients will get a different answer?
I think it's a conversation, and it's going to be the same conversation. No, I think it depends on the quality of physicians, and we want to have high quality physicians that mirror the quality of our physicians who are seeing patients at East Ann Arbor or here in Taubman or wherever. And these are, as a physician, these are questions you have to address. You can't not address them. If we were to hire somebody who, every time somebody said they needed an MRI for a headache, said, okay, MRI for a headache, that person wouldn't be the kind of person, the provider that we're looking for.
You know, I think it's important, Victor's care or non-Victor's care, that we all practice the standard of care. You know, I'm in clinic today, even today, I had to tell a parent that their kid does not need ear tubes. Yet that was distressing for them to hear that, because you know they didn't meet the indications for it. And so I think that it's important for Victor's care or non-Victor's care that we practice by standard guidelines and that we make recommendations. Even as a clinician in Michigan Medicine, I have to have difficult conversations with parents who demand a CAT scan, demand some type of surgery that's not necessarily indicated.
Yeah, one last comment about that. Thank you for saying that, David. I think that we need to have our standards across the institution, and many of you have to have these conversations, as David just mentioned. If we have a patient who, after those conversations, is dissatisfied because they can't get their whatever test here, they'll leave, and that'll be okay. We're not going to try to retain them by bending to what their view of what they need medically is if we don't endorse that.
Great. The next question regards the philanthropic goals and mission, either stated or unstated, of this program, and is really related to Dr. Runge's comments earlier about the role of philanthropy here. So the question broadly for the panel is, how best can we either use or recruit philanthropy funding out of this program, and what would be the best utilization of it?
Let me talk about the recruitment of it, and then let somebody else talk about how to best use it. Because I think how we best use it, I think it ought to go into clinical care. I think it ought to go into clinical care for those who are vulnerable. And I've told everyone that I've talked to that same statement. Since I spend a lot of time on the recruitment of funding from donors, my experience has been that donors will give to what they want to give to. But they won't give to something that they might want to give to if they didn't know about it. So we always provide a menu. And here's a menu. But for everyone who's in the Victor's program, number one on that menu is going to be, would you be interested in supporting this initiative? This initiative being something that would be for the care of our vulnerable patients. And we can't make them do that, but my conversations 2 weeks ago make me feel pretty positively that there are people who are very interested in it. They've done well, and a lot of the reason we do so well in philanthropy is most of our donors have done very well, and they feel like it's their responsibility to support our missions.
One idea that was suggested to me by Bernard Lowe, the head of the Greenwall Foundation, was actually the idea of actually building a panel of vulnerable members of our community to tell us what the funds should be used for, what their needs are. Because sometimes we think that the need might be clinical care, but they might actually think that research into a problem that disproportionately affects them, or recruitment and training of their young people to join the medical profession might be a better use of the funds. And I think we have experts in the audience who have engaged vulnerable communities in their work. Susan Gould is sitting in the second row right here. We know how to do this, and so I think this would be very important.
So I agree that this should go back into the clinical care mission. You know, OHE and Keith Grant and the Office for the Patient Experience we already have opportunities to engage patients, and our goal is to expand that patient engagement to more marginalized or vulnerable patients, and this can help us with their experience in their care. I also think that the money obtained from this should also fund the research to evaluate it, and other missions and priorities at Michigan Medicine, including education.
Great. The next question regards what happens when these patients are admitted, what happens when these patients show up in the ER. And the narrower question is, will they get priority or not? But I think the more interesting, broader question is, how as an institution should we view these patients? And is there a fundamental difference in our approach as clinicians, knowing that someone is a Victor's Care patient versus not?
So a couple of comments on that. The first is really speaking to what Reshma said earlier about, I don't know if it's a real or theoretical chairman of surgery story. Our patients are going to get the best care in the hospital if they come and get our hospital care. I have confidence in our care in the hospital, and so these patients will be no different than anybody else when they're in the hospital. Now, we're not planning on having the Four Seasons menu for them, which some hospitals cater. They have separate wards. We're not talking about that. We're talking about, and they will likely occasionally end up until we decant all our double occupancy rooms, they'll end up in a double occupancy room. And we'll be getting the same calls that I get every single day. Can you get so-and-so out of the double occupancy room? Across the spectrum. So their care should be just like their care. Now, the emergency room, I think it's been interesting with patient-facilitated services. My understanding, and I haven't been here, I've been here 3 years, is they used to get down there and try to worm them through the emergency room. They gave up on that. And I don't think they do that to my knowledge anymore, and we don't intend on doing that. But that said, we have a massive way to go in terms of improving the experience of our patients in the emergency room. And we can't go on without addressing that in a very, very serious way. There are many components to that I won't go into today because they're not really particularly relevant to Victor's. But our goal is their experience is the experience.
I think we can't afford to deviate from our standard of care. When we deviate from that, that's when errors and things fall apart. I'll share a personal story. When I was at Hopkins, I had carpal tunnel syndrome and I was going to have surgery, and I researched the best plastic surgeon to do it endoscopically. And one of my personal mentees happened to be on the rotation, and he was going to be scrubbed in the case. And he comes to me and says, Dr. Brown, he says, do you mind if I participate in your surgery, or do you want me not to do anything? I said, I want you to do whatever the surgeon does to achieve his 95 and above success rate. If he says, cut this, cut that. And because that is how we're successful. Once we deviate from our norms, that's when errors happen, and that's when bad outcomes happen.
I haven't tried to say anything humorous, but I'm going to tell you a little humorous anecdote. When I was in North Carolina, the person who preceded me as chair of medicine, wonderful guy named Fred Sparling. Fred was working on his roof for some crazy reason, fell off, broke his leg. So he comes to the emergency room, and the people at the front desk are scurrying around. Oh my gosh, it's the chairman of medicine. We got to find him a room. We're backed up. So they put him in a room. And he's sitting there, and people keep walking by, and they look in and they keep walking by. And so this goes on for quite a while, for an hour. And he's thinking, what the heck? And they're not want to see me because I'm chairman of medicine. So finally, somebody gets up there and he drags himself over and opens the door and says, why won't anybody see me? And they say, well, Dr. Sparling, this is the psych room. no one wants to see you. So just as a mildly humorous example of how if we treat people special, we don't really treat them specially.
Great. So I'll use that as a little bit of a segue to the fact that there are mechanisms in place already through the development office and others to take care of, for lack of a better term, either donors or VIPs.
Yes.
And that program has existed for a very long time and is distinct in some ways from Victor's, but there's clearly some overlap. And the question is, are we fundamentally treating Victor's Care patients as we do the VIPs through development, or is this different? And is there a way, coming back to Dr. Jagsi's earlier comment, of being more transparent about what we do and don't offer people who we value due to their philanthropic potential?
I'm getting a lot of these questions. So on that one, I do agree. It's hard to know exactly what PFS, patient facilitated services, does, because it's a one-to-one personal experience. What we're trying to create is a system that provides a way to access our healthcare, not bumping anybody out of the way. I think so if you try to do this as a system rather than as an individual one-off, I think we have lessons to learn. And those lessons may or may not be expandable or not, but I think this is a chance to do that in a very different way than PFS. So this is not a recreation or enhancement of PFS.
Thoughts on that? No. Great. So we have a few minutes left, and I want to leave time for a few final comments. Just my perspective, for whatever it's worth, is that there's a fundamental difference when we think of any concierge program with regard to the optics and the ethics. And they are clearly related. When we think about what something looks like on the surface, that is different fundamentally from what it actually is in practice. And I think some of the concerns related to Victor's were more related not necessarily to what it actually is, but rather what people were afraid it might be or what the surface looked like. And I think one of the really strong values that Michigan medicine has is transparency and accountability and openness. And I think it's really a testament to our senior leadership here that we are all sitting in this room together having this conversation. There are many institutions where these types of programs happen in the shadows. And I think one of our strengths is the fact that when our broader community had concerns, we came together as an institution and have a very public, very frank, very open conversation about it. With that said, I think when we're thinking at a higher level about the ethics, the issues of accountability and diversity and equality are important, and it's just as important to recognize when we're not honoring them, that we are creating a different level of service for different members of our community. And I think it behooves us, from a Rawlsian approach or from any other organizational approach, to think about when and how that's okay and why that's okay. So for example, again, if we are truly using a Robin Hooding example where we are taking philanthropic donations from those who have the capacity to do so and reinvesting them in those who cannot, I think that is very clearly a transparent mission that we can get behind, or at least many of us can get behind. When this is opaque, though, I think is where we run into problems. Dr. Brown?
Thank you for those comments, Dr. Shuman. I think we need to be very intentional in evaluating the disparities that already exist in our patients and that may be exacerbated by this. And we also need to be intentional about the access and care for all patients, vulnerable, for people who feel excluded or marginalized. And so this is kind of like an intentional program for people who value this and have the money. I think similarly, we need to be intentional about the other 85%.
I think that's very well said. I will say one last thing about the people who enroll in this program. I found with donors, they are sophisticated. You can just say it right to their face. The point of this, which I said. In fact, when I didn't start out, the first couple of donors I didn't start out, they said, well, what's the point of this? Isn't it to raise money? And I said, yes. I mean, why else are we talking to them, really? I shouldn't say that. Excuse me. Withdraw. But they want to do good. What I'd like to close with is a thanks to David and Reshma, who I think bring a really unique view into how we can make this kind of program we all can be proud of. I want to thank all of you for taking your time, but I also look forward to hearing from you about how, again, we can get feedback from you, from our patients, to really make this kind of program that we will be proud of and rein it in when it's not. And thank you for Christian and Andy for allowing me the opportunity to be here and for setting this up today.
Thank you all. The final comment I'll have is that the Center for Bioethics is certainly committed to this work, and we are very much committed to working with the Dean's Office and the broader community to engage the community, engage our broader community outside of Michigan medicine in making this something that we can be proud of. And I would like to thank you all for your attention and your time. Have a wonderful day.